So is it going to be possible to stream the other one? Okay, we'll wait for a few more minutes.
Yeah.
All right, I think we can start now. Good evening, everyone. Thank you for coming. My name is Adnan Hasanovic. I'm AP Director here at Lenox Hill Pathology, and I'm also overseeing cytopathology operations here. Welcome to our second evening of cytopathology here at Lenox Hill. Thank you all for coming. Tonight we have two distinguished guests with us, Dr. Sara Monaco from University of Pittsburgh Medical Center in Pittsburgh, and Dr. Eva Wojcik from Loyola University Medical Center in Chicago. I would like to take this opportunity to thank Dr. Wall, our pathology chair at Lenox Hill, also to Dr. Jim Crawford, he's a system chair of pathology, for supporting and promoting this evening's gathering. And although I have a privilege to give the introductions, all the hard work and heavy lifting to organize this meeting were done by Cari Tolentino, our cytology supervisor, her team of devoted cytotechs with Lucille, Barbara, and Terry, Arjun Woodley, who's took care of the food and everything, and of course Chiara Shugru, she's our administrative director here at Lenox Hill. Tonight's meeting will be broadcasted live via YouTube, so we'll have a outside audience as well. Thanks to our technology savvy resident Saida Siri over there. Now let me introduce our first speaker, Dr. Sara Monaco. Dr. Monaco is associate professor at University of Pittsburgh Medical Center, specializing in non-GY and cytopathology. Dr. Monaco has a medical degree from Columbia, and also she did her residency at Columbia University, followed by fellowship at Pittsburgh. She's currently cytopathology fellowship director at UPMC and also director of FNA aspiration services. Her research interests are fine needle aspiration, biopsy diagnosis, cytology, histology correlation, pediatric cytopathology, and molecular diagnostic in cytopathology. She has co-authored numerous articles in leading peer-reviewed journals, and I will stop here. I will not take any more time, and let's welcome Dr. Monaco.
Thank you to Chiara and Adnan and the department for inviting me. It's always a pleasure to be back in New York. I grew up not too far away in Ardsley, New York, and spent almost 10 years of my life on the Upper West Side at Columbia for med school and residency. So it's always nice to be back here. So today I'm going to talk about minimally invasive biopsies of the lung and mediastinum in this era of personalized medicine. So I do hail from Pittsburgh now, and being a New Yorker in Pittsburgh is not always easy, because when you want a Yankee score, all they're interested is the Steelers off season. But I sort of made it work. And there's a lot of things about Pittsburgh that are pretty unique and pretty interesting. So it's always a good place to visit if you ever get the chance. We actually have a lot of Uber self-driving cars now floating around the city, which is kind of cool, things you may not see in New York every day. So I'm going to start about talking about minimally invasive biopsies and really why they've taken off and how we sort of approach the diagnosis in these lesions. And then I thought I'd move on to sort of a case-based approach to show some interesting cases we've had in Pittsburgh that I think really illustrate some of the pitfalls and a lot of the morphological challenges that we're seeing now that can impact ancillary study requests. And then I'll end with some concluding statements. So as we know, in the mediastinum and lung, there's a variety of different non-neoplastic and neoplastic entities. And for that reason, once a mediastinal or lung lesion is found, really the onus is now to find what kind of tissue can we get from that mass to determine what's going on. So why minimally invasive techniques? So as we know, about half of lung cancer patients actually present with metastases. And so you're able to diagnose and stage these patients with a single procedure, which has been a big advantage. In addition, minimally invasive biopsies offer a shorter length of stay and decreased costs compared to more invasive techniques like surgery. And that's really sort of improved patient care and decreased healthcare dollars. There's also this need for subtyping and molecular data, and because we've done a good job at it, there's been this sort of thrust to do more with this and sort of avoid the need for more tissue, and to sort of avoid the need for complete surgical excision if that's really not what the patient needs. Cytology has been shown to be sort of superior for morphology and can be very good for subclassification. A lot of this is because we use multiple stains. We're not just confined to an H&E. And some of our stains, like the PAP stain, provide better nuclear and cytoplasmic detail if we're looking for squamous differentiation. Comparison to sort of frozen section and things like that, there's less fixation artifact. And there's this ability to sort of do on-site evaluation to appropriately triage and allocate material for the appropriate testing. And I think on-site evaluation has been particularly helpful because once you have a diagnostic material on the slide, I think that really the impact of doing dedicated passes for cell block collection and not making excessive slides can really be helpful. So because small biopsies and cytology specimens have been so great, there's been an increase in these specimens. And with the increase has come new approaches to how we can do these biopsy techniques. And there's actually a variety of different needles that we have to choose from now, and I'll sort of review some of the ones we've been having experience with in Pittsburgh. And sort of this increased demand for small biopsy and cytology specimens has really prompted new classification systems for these small biopsies, and sort of the expanding need and use for these small biopsies for biomarker testing. And really, it's not enough to just make a diagnosis anymore. You really have to have enough tissue to do all the studies that are required. And as we know, those required studies are increasing almost every day with a variety of different things that clinicians are asking for. And we'll review those as well. So as I mentioned, mediastinal lung lesions, these are non-palpable lesions found on imaging techniques. And then we move on to a variety of different minimally invasive diagnostic modalities, from the traditional ones that we're all familiar with, like BAL, CT-guided FNA, to some of the newcomers of the group that have really increased, and that's sort of EBUS, transesophageal EUS-guided FNAs, supranavigational or electromagnetic navigational bronchoscopic biopsies, and now sort of endobronchial biopsies. I feel like we see more of now sort of for touch prep evaluation opposed to frozen section diagnosis. And I'm going to sort of focus on EBUS, guided transbronchial needle aspirations, as sort of an example of how these minimally invasive techniques have sort of impacted us. So as we sort of, I'm sure most of you are familiar with EBUS. Just out of curiosity, I'm just interested in how many people here are evaluating EBUS specimens in their labs. How about navigational bronchoscopy specimens? Okay, so I think most people have seen less navigational bronchoscopies than they do EBUS, but I would say EBUS is pretty prevalent now, and most small hospitals are even doing it. And it really arose because it was a minimally invasive technique and it had real-time image guidance. And that real-time image guidance, the ability to see the needle in the lesion, improved upon the blinded techniques that came before it, like the transbronchial Wang biopsies and things like that were really blinded techniques. And now you've basically obtained the ability to confirm any positive or PET findings or CT findings. And that's particularly helpful in small lymph nodes that may not be accurately characterized by imaging techniques. And then you have a broad sampling capability where you can actually sample more than just mediastinoscopy alone. As I mentioned, you can do on-site evaluation and triage that specimen, and the lower cost, of course, is also helpful. And in Pittsburgh's early data, about basically 40% of patients that were clinical stage 3 based on imaging were actually downstage with EBUS. And so this has made a big impact on our practice, because a lot of these patients who have positive for malignancy on EBUS are spared more invasive surgery. So EBUS has really been sort of our go-to sort of triage technique when patients present with mediastinal lesions. As I mentioned, the sampling capability with EBUS is far better than with mediastinoscopy alone. So if you look at this image, actually the nodal stations that are highlighted in royal blue are really the only stations accessible by mediastinoscopy. EBUS allows you to hit the sort of the blue and the green, and with transesophageal EUS guided biopsy, you can actually hit the red. And this is really why a lot of people theorize that EBUS and transesophageal EUS guided biopsies together really are the complete mediastinoscopy. Now, minimally invasive small biopsies, in particular EBUS, have some real specific advantages that also make it superior to surgery. One is restaging of the mediastinum. So any patient who's had prior thoracic surgery, that had prior surgical fibrosis and things like that, it really may be unsafe to go back into that mediastinum and to get tissue when they have a relapse or recurrence. And EBUS really allows you to sample those patients in the safest technique. Then, as I mentioned, you have small lymph nodes, which really are hard to characterize by imaging modalities. You have poor operative candidates, and I think some of these poor operative candidates do really well when you do an EBUS under conscious sedation, opposed to general anesthesia in the OR. And being able to offer them that is much better than taking them to the OR. Non-surgical diseases, in particular benign things, lymphoma, and even metastatic carcinoma, when really the patient has benefited from not having surgery and can then have expedited other treatment. And then, of course, being able to do biomarker testing on small biopsies and allowing that patient to get targeted therapies without recovering from surgery is also another distinct advantage. This is sort of the clinical algorithm that we follow in Pittsburgh, and basically lymph nodes that are greater than 1 centimeter or PET positive then go for EBUS. And then if those patients have a diagnostic positive EBUS, they basically go on for treatment and are spared mediastinoscopy or surgical lymph node sampling. And I feel like there's a thrust now that even in some diagnostic negative cases, I feel like some of those patients are even being spared surgery as well as we get more better at doing it. So what's new with EBUS? I mean, I've talked about EBUS for the past decade, and everybody pretty much is doing it and knows about it. So the new stuff that's going on with EBUS basically comes down to new equipment devices, so new needle sizes, new types of needles. We have a Procore needle that's now available, and new designs that offer sort of improved maneuverability, getting out to the hilar lymph nodes, and even better visualization on the ultrasound. And we'll look at some of those new designs in the coming slides. And then there's this increasing demand, and how do you manage on-site evaluation? Some people are doing having traditional on-site evaluation with their cytotechs only. Some people are sending their cytopathologists, and some people have moved on to telecytology, where they're doing it with remote evals because of the increased demand and sort of the permeation of EBUS into locations that are not easy for the pathologist to get to. And even in Pittsburgh, we are moving to telecytology in the coming month. So we will not really be in the OR anymore. We'll be using remote cytology evals. And then recently we've been asked that, you know what, we need cytology on call all the time, because we don't want to offer patients inferior care if they come late at night or on the weekend. And so we actually have a cytology on call service now, where a cytotech is on call for late night or weekend procedures. And that really came because the clinicians, the thoracic surgeons, have said that we just have to offer this to patients on the off hours. And then it's this issue of sort of optimizing tissue. I think every thoracic surgeon wants to make sure that their cell block is the best, and that the hematologist or oncologist is not going to come after them for more tissue. And so it's sort of getting more and doing more with less. So these are some of those new needles that I talked about. This is one of the EBUS Procore needles, and the distinct advantage of this one is that it has 2 bevels. One looks sort of like a shark tooth, so that when you're taking your excursions back and forth, that second shark tooth is sort of grabbing fragments of tissue. As you can imagine, it sort of does a little bit more tissue damage when you're doing the biopsy. We used it for a while. It sort of fell out of favor when Olympus came out with their sort of larger gauge needles, but we were using it for a while if the initial EBUS was non-diagnostic. And this is just from an ASC abstract that we did on Procore. And it did help in certain procedures. I think we were getting bleeding after the first pass due to the sort of tissue damage, and it prevented from getting good specimens thereafter. This is the new Olympus needle. That's a 19 gauge needle. And you'll notice that it has sort of this spiral marking sort of along the shaft near the needle, and it's thinner. And so this spiral markings basically help make it more echogenic so you can see it better on the ultrasound image. And it also has this design where it's very thin and the caliber of the needle is actually wider. And this has sort of allowed for better maneuverability. So when the bronchoscopist is going out to the hilar lymph nodes, these needles actually bend and give them more flexibility when accessing the hilar lymph nodes. And then electromagnetic navigational or superdimensional bronchoscopy is sort of the GPS device that allows you to go to sort of lung lesions without doing a CT-guided FNA. And I would say we primarily use this for patients who have really bad emphysema and bullous disease, where basically doing a CT-guided FNA could sort of cause a pneumothorax or other complications. And this is sort of that way to navigate to the lung masses without going through the thoracic cavity. So as I mentioned before, because we've had this sort of increased demand for small biopsies and cytology specimens, this has sort of prompted the new classification systems, primarily the International Association for the Study of Lung Cancer, the ISLC guidelines, and in addition to the Papa-Nicolau cytology guidelines. And so I'm going to review those. And then there's this sort of a need for the biomarker testing, which we'll also sort of review. So in the past, our classification for lung cancer in cytology was relatively easy. We had this dichotomous classification where we called it non-small cell or small cell. And that really wasn't enough for today's day and age, because now we know that squamous cell carcinomas actually can have adverse reactions to some drugs. And some of the squamous cell carcinoma patients don't respond as well to certain things like antifolate inhibitors like pemetrexed. And so it became really onerous, or it became really important for us to distinguish not just non-small cell, but to actually say whether that non-small cell was adeno or squamous. In addition, as we know, adenocarcinomas have a lot more driver mutations. So we are sending the adenocarcinomas or non-small cell favor adeno for molecular testing. And so this sort of subclassification of the non-small cell was a real change for cytopathology, for the cytopathology community. In 2011, the IASLC guidelines came out for small biopsy and cytology terminology. And basically it said, you should call it adenocarcinoma or non-small cell favor adeno, and likewise squamous cell or non-small cell favor squamous cell. In addition, it left open this sort of non-small cell NOS category where there really is no definitive adenocarcinoma, squamous, or neuroendocrine morphology. And I hope that the cases today that I show you will sort of indicate just how far you can go and when you should avoid calling it adenocarcinoma up front versus non-small cell favor adeno or non-small cell NOS. I'll just mention, in the right-hand side of the column is the WHO classification that was published in 2015. And basically, for those resection histology specimens, they do subtype adenocarcinoma into the 5 patterns: lipidic, acinar, papillary, solid, and micropapillary. And currently we don't have to do that in cytology. So our job is a little bit easier by just saying whether it's adeno or not. We really don't have to give the histological subtypes. This was a paper that we did in Pittsburgh a while ago when the ISLC classification system came out. And I like to show it because basically it shows why we don't do the subclassification of adenos, because we don't really reliably do it very well. And part of the problem is that a lot of the adenocarcinomas are mixed histological types. So there's a certain percent that's acinar, there's a certain percent that's solid. And so based on a small sample, you're not going to be accurate in subclassifying it. So what we did was we took resection specimens that had a single histological pattern and looked back at the cytology and said, even when it's a single histological pattern, how well do we do? And we didn't do great basically in defining exactly what subtype it was. But what it did show is that basically you can separate prognostically poor subtypes, like the solid subtype, from better performing subtypes like the acinar or the lipidic types that are sort of have a better prognosis. So I basically show this because although our job is just to say adenocarcinoma right now, in the future, perhaps we will have to do nuclear grading or indicate whether there's necrosis or signs that that adenocarcinoma is a higher grade or more worrisome aggressive subtype. But for now, we don't. In 2016, the Papa-Nicolau Society of Cytopathology basically published the respiratory cytology guidelines. And a lot of us were pretty familiar with these guidelines because it basically was just reiterating what most of us have been doing. So there wasn't an earth-shattering change. I think the biggest change is then once you can get to the malignant category, then subtyping and saying whether it's a non-small cell and what type of non-small cell. And that's really where the IASLC guidelines hit in there once you get into that malignant category. So basically, when you have a lung tumor, you're basically trying to decide which sort of category to put it into. And a lot of the adenocarcinomas and non-small cell NOS then go on for molecular testing. And as I mentioned before, the molecular testing guidelines have changed. Before we were basically doing EGFR and ALK, and now a lot of places are now adding ROS, in addition to a variety of other things. And when you move to NGS testing, you can do a lot more with less tissue. So it's a lot easier. This is just a comparison from what we were doing in Pittsburgh in 2012 compared to 2017. These are sort of our theranostic summary statements that go on the end of every lung cancer case. And basically you can see there's been a dramatic change in the number of mutations that we're looking for, in addition to doing PD-L1 testing. So even within 5 years, our summaries and our molecular testing has expanded dramatically. And it's funny because when I look back, we weren't doing NGS before. We were doing a lot more blanks, a lot more slides for less information. And now with NGS testing, we're sending 6 blanks and sort of generating a lot more information. So you truly are getting more with less tissue. So in terms of optimizing tissue, in addition to sort of helping your operator get better tissue, whether it's their needle or their technique, I think basically having on-site evaluation and being able to triage material, whether it's dedicated passes or a concurrent core biopsy for molecular testing, is very critical. We also do upfront blanks, sort of a lung protocol in any case we think may need molecular testing, to avoid trimming the block and coming back to it later. And these unstained charge slides are basically numbered in order. We limit the immunostains, and then those slides can then be sent to whatever labs require it based on the diagnosis. For the cytotechs in the audience, if you know about the EBUS needle and you've been on site, as I'm sure most of you have, it's a long needle. So we've sort of trained our operators to sort of avoid putting that needle in the sharps container and giving it to our cytotech so they can sort of rinse that needle, and then we dispose of it in the sharps container. So really sort of getting as much as you can from those needles can be very helpful. So this is a question I get a lot from some pathologists. You know, the patient had prior molecular testing. Do we still need to collect for molecular? And sometimes this gets sort of permeated through to the thoracic surgeon. He's like, hey, this patient had molecular workup. We're just trying to prove recurrence. Do we really need to collect more for molecular? Usually the answer is yes. If they've had a prior EGFR mutation, obviously you want to look for a resistance mutation. And in addition, so much of the testing has changed now that a lot of our patients coming back with recurrences never had PD-L1 testing, and they're going to request it. So I think it's always better to sort of treat it like you're going to test and try to collect material for biomarker studies in case it's required. So PD-L1 testing, I think everyone is sort of dealing with this headache and trying to implement that in their labs. Most of us know, so we're looking for a PD-L1 on the tumor cells, and basically that helps in selection of patients for PD-1 inhibitors. And the problems and headaches with PD-1 have included that there's multiple drugs available, multiple different antibodies and testing platforms. We happen to be a Ventana system, and so implementing a Ventana antibody versus other antibodies, all of these issues come up. There's different clinical trials with different cutoffs for each sort of drug and determining whether it's positive or negative. And some patients seem to respond to the therapy even if deemed PD-L1 negative. So it sort of raises the question, you know, how long are we going to be doing this for? And, you know, will the guidelines change? And I think probably the most important is that we're seeing an increased demand from clinicians for PD-L1 testing and an increasing number of tumors. It started with lung cancer and melanoma, and now I feel like we're seeing renal cell carcinomas, bladder cancers, a lot of demand. So it's really not just the thoracic specimens where you want to make sure you have enough specimen. And PD-L1 testing in small biopsies in cytology, some people don't test it on cytology. We happen to test it on cytology specimens. And you can see it's easy when it's positive. It's easy when it's an earth-shattering positive case and when it's a negative case. I think we struggle when it's sort of not an earth-shattering positive case and you're trying to quantify, is this 5%? Is this 10%? Is this greater than 25%? And there's a lot of heterogeneity in these specimens. And so I think the real test, you know, is how will these patients do with treatment? And so that's sort of going to require follow-up studies. One thing that we've done is sort of image analysis on some of these cases to look to see, you know, what we would call it manually and what the image analysis would call it. And these are just some of the discrepant cases. And I just mention this because as people sort of bring on image analysis, I think these are some things we have to be aware of, that some of it requires a little bit of oversight. So for example, in like C and D, you know, the manual consensus review by pathologists was that there was about 20% of cell staining. And for us, 25% was the cutoff with the SP263 Ventana antibody. Image analysis called it positive with greater than 50% positive. And when you look at the breakdown, a lot of that was weak intensity in almost the majority of those cells. And so, you know, basically, you know, is image analysis picking up some weaker staining that our eye isn't picking up, or is it overcalling some staining? And so I think when we bring on this sort of stuff, it's probably going to require pathology and cytopathologist oversight to make sure they're looking in the tumor cells and to make sure that the machine is actually counting the right cells. So I thought I'd move on to sort of a sampling of interesting cases that sort of bring up some pitfalls and some of the morphological challenges that we've seen in Pittsburgh sort of impacting our ancillary study choices. So this was a CT-guided FNA of a lung lesion. This was a 63-year-old woman with a history of melanoma in 2012, and it was a vaginal wall tumor. And then she presented to us with metastases in 2015 to the liver. She was BRAF positive. And she was then sent for nivolumab treatment when she presented with metastasis in 2015. And that's sort of was 18 months prior to her biopsy in Pittsburgh. And basically she had a lung biopsy because there were these consolidative pulmonary opacities. And one was actually quite significant in size. You can see here this sort of consolidative opacity. And the question was, you know, is this recurrence or metastasis of her melanoma? Is this a new lung tumor, or could this be an infectious process? And you can see sort of these ill-defined sort of ground glass opacities and more of these consolidative mass-like opacities. So she had a CT-guided FNA of the larger opacity. And this is basically what we saw. It's kind of sort of squamoid-looking cells with some nuclear enlargement. Other areas where there's some prominent nucleoli. I think overall the NC ratio is not super high. And so it sort of makes you say, you know, is this sort of a well-differentiated adenocarcinoma or non-small cell, or could this just be something that's not tumor? Here you can see almost what looks like sort of a vague granuloma, maybe some crushed lymphoid cells. On the PAP slide, again, you can see some cells here that sort of have some prominent nucleoli, but not a lot of nuclear irregularities and really not slam dunk features for malignancy. This was the cell block, which actually had a few fragments of lung parenchyma that kind of looked like they were chronic inflammatory cells and some eosinophils, as you can see there. And then more of these epithelial cells that sort of have some prominent nucleoli, but also have moderate amounts of cytoplasm. And so we were, in this case, we were sort of worried that maybe this is a well-differentiated adenocarcinoma, but we really couldn't rule out that this was something reactive or benign. So we actually called this atypical and favor reactive. We then did bug markers, was sent for culture, and basically they were all negative. So then this case was brought up at tumor board that perhaps this is toxicity due to the PD-1 inhibitors that she was on. And pneumonitis from these PD-1 inhibitors is sort of a well-known complication that can occur. And usually these patients will respond to discontinuation of the drug and sometimes steroids. So basically her Nivo was discontinued, and on follow-up, most of the lung lesions were completely resolved, and just a few ground glass opacities remained but seemed a lot smaller. And so this was basically changes attributed to reactive pneumocyte atypia in the setting of PD-1 inhibitor toxicity or pneumonitis. And here you can see before and after on her CT scan, where a lot of these sort of ground glass opacities and even the largest sort of density are actually gone. And so adverse pulmonary reactions with PD-1 inhibitors are sort of thought to be sort of this autoimmune related sort of pneumonitis. It's seen in about 14% of patients on phase 2 and 3 trials. Usually there's a greater percent of patients that have a lower grade toxicity and really very few that have this high grade toxicity. Respiratory failure and death have been attributed to this in only about 3 patients. So it's very rare to go on to cause failure and death. And usually the patients present with infectious-like symptoms of pneumonia, and they have these bilateral sort of lung infiltrates or opacities, And when they get larger and they look ground glass or like a mass-like consolidation is when they usually present for biopsy, particularly because these patients are on a PD-1 inhibitor because of a history of malignancy. And the concern is always to rule out that it's not an infection or recurrence or metastasis. And usually this occurs 7 to 25 or 24 months after treatment. And in studies looking at surgical specimens, they tend to be CD4 positive T cell predominant infiltrates when you look at them. And they also tend to have a mixture of sort of lymphocytes and EOs. This was the New England Journal of Medicine article looking at PD-1 inhibitor related pneumonitis after cancer immunotherapy, and kind of shows you the variety of different imaging ways it can present, with sort of a lot of sort of effusion and consolidation of the lungs to more of this reticular and ground glass opacities, and also sort of mass-like lesions. So this sort of raises the issue of benign or reactive changes that mimic malignancy. And so when you think about this, we think about sort of therapy-related atypia, metaplastic changes, even in peripheral lung lesions. Sometimes mesothelial hyperplasia can mimic malignancy. One that's always been difficult for cytology is granulomatous inflammation, particularly when you have very cellular granulomas with very epithelioid histiocytes and prominent nucleoli. And then there's sort of contamination of the FNA needle by sort of benign or reactive or non-neoplastic or changes. And this was sort of reported in transesophageal guided, EUS guided FNAs, where proceduralists going through Barrett's esophagus or Barrett's dysplasia, going into sort of a mediastinal lymph node, could sometimes catch Barrett's esophagus, and that could be misinterpreted as being metastatic tumor. We don't see that contamination by the primary tumor or dysplasia in the lung as much, obviously, because we're usually biopsying far from the tumor mass. But in transesophageal EUS-guided FNAs, a lot of times there is some luminal dysplastic changes, and if you are putting a needle through there, that contamination could lead to an overdiagnosis, potentially. So it's just something to be aware of. So just to sort of show some of these, this is goblet cell metaplasia. I always think this is kind of interesting because when we see it and it has sort of ciliated respiratory cells intermixed, it's easy to say, okay, it's just goblet cells. I think sometimes when you just have a few goblet cells, well, sometimes the question is, could this be a signet ring type adenocarcinoma that I'm missing? And this is important on EBUS because if you see this, this is basically just contamination by goblet cell metaplasia in the bronchial wall, and really does not mean that they sampled the lymph node of interest. So it really would be a non-diagnostic FNA. So I always point out to my fellows and residents that, falsely assuming that this is atypical or possibly lesional could give a false sense of security to the proceduralist that they're actually in that mediastinal lymph node, when actually it's just a contaminated FNA specimen that really has not sampled that lymph node of interest. On the bottom here are two other benign things to think about, sort of lymphohistiocytic aggregates in benign lymph nodes and sort of cellular granulomas. And sometimes these benign things can also mimic malignancies like adenocarcinoma. And so those are two things to also keep in mind. So the take-home messages from case one is that in the era of personalized medicine with these new therapeutic agents, particularly with PD-1 inhibitors, think about treatment-related changes. PD-1 inhibitor toxicity could happen in basically anyone on those PD-1 inhibitors, so it is important to get a good clinical history. We've also seen some new sort of treatment-related changes in patients with autoimmune disease, particularly rheumatoid arthritis or Crohn's disease, being treated with immunomodulatory agents like TNF inhibitors. And these can cause sort of sarcoid-like granulomas and necrotic changes in lymph node and the lung. So that's another thing to sort of think about when you think about these patients and you have their clinical history. And of course, we all know about sort of radiation and chemotherapy related changes that for years we've known about as sort of mimicking malignancy. And always think about drug-induced toxicity, because really withdrawal of the agent is really the best medicine in this case. And so sometimes the best medicine is no medicine. And so these are always things to sort of think about. Okay, so the next case I was going to talk about is an electromagnetic navigational bronchoscopy. So we don't do a lot of navigational bronchoscopy in Pittsburgh, but we see a fair amount of them. And as I mentioned before, it typically is patients that have really bad bullous disease of the lung and emphysematous change, where they think that a CT-guided FNA is really sort of unsafe. And they think they can reach it with a navigational bronchoscopy. So this was actually a 40-year-old woman with a right lung mass, and she was a non-smoker. And she was presented at an outside hospital with a 3-centimeter lung mass. It was previously biopsied and was called squamous cell carcinoma. And the clinicians requested a repeat biopsy because she was a non-smoker and she was young. And so they found the diagnosis of squamous cell carcinoma to sort of not be consistent with what they were thinking. And so she had a navigational bronchoscopy and biopsy of that lung mass. And you can see here on the diff-quick and the pap stain slides, I think the thing that catches us right away are sort of the cells that look sort of squamoid. They have this sort of dense cytoplasm sort of stretched and some nuclear pleomorphism. In addition, there are also these sort of more glandular appearing groups that also have some atypia. You can see here, some of them have more prominent nucleoli, and they actually look quite different than the squamous cells. But you could see how the squamous cell carcinoma really catches your eye cytologically much more than the glandular component here. On immunostainings, part of the malignant cells appeared P40 positive, and another component seemed TTF1 positive. So we actually called this non-small cell carcinoma and commented that there could be a squamous and glandular component. And on follow-up, she was found to have an adenosquamous lung carcinoma. And on molecular testing, she was actually found to be EGFR positive. And so this sort of highlights the pitfall of when you have sort of an adenosquamous lung carcinoma. There are actually a fair amount of these that have driver mutations, and particularly EGFR. And a diagnosis of squamous cell carcinoma could really exclude that patient from getting molecular testing and potential targeted therapies that may be of use. So as I mentioned before, you know, our job is to sort of put it into a diagnostic compartment, and then some of that will triage what molecular testing gets done. And so when you make a diagnosis of squamous cell carcinoma, you really have to ask yourself, you know, is the patient a smoker? If not, should I think about something else? Is the patient older or is the patient younger? And in addition, you should always say to yourself, is there any possibility that there's a glandular component? Is everything P40 positive, or is there something that's TTF1 positive that suggests maybe a glandular component? And I think we're lucky that we have sort of this non-small cell NOS category, and that we don't want to overuse that, but in cases where you're not convinced it's all squamous, I think it's better to err on the side of calling it adeno or non-small cell NOS, because that will prompt molecular testing. And if they do have a driver mutation, you'll catch it and not really exclude that patient if they do have a driver mutation. So adenosquamous lung carcinoma is, you know, rare. It's less than 5% of lung cancer overall. And it tends to have a more aggressive behavior and worse prognosis than adenocarcinoma. And some reports even say even worse than squamous cell carcinoma. It's frequently treated more like adenocarcinoma given the high frequency of EGFR mutations. This is just what, you know, just to reiterate the ISLC guidelines that for the WHO classification for adenosquamous carcinoma, you know, both components need to be greater than or equal to 10%. And obviously that's hard on a small biopsy to know what percent of each component you have. So lucky for us, as long as you think that there could be a squamous and adeno component, you can basically call that non-small cell not otherwise specified with a comment saying that you think there are some glandular and squamous components, and usually those patients will then go on for molecular testing. So I think that the danger is to call adenosquamous cell carcinoma squamous cell carcinoma and to sort of eliminate that patient from molecular testing. So this was like a great paper that came out that looked at sort of driver mutations and prognosis in adenosquamous cell carcinomas and compared it to adenocarcinoma. And what you can see is sort of this blue piece of the pie are the EGFR mutations. And so although there's less EGFR mutations in adenosquamous, there is still a significant proportion of those patients that will have that as a driver mutation and could benefit from those tyrosine kinase inhibitors. And funny enough, or it kind of makes sense, I guess, that your odds of getting detecting the EGFR mutation depend on how much of a glandular component or a squamous component you have in that specimen. So obviously the adenosquamous carcinomas with more of a glandular predominance have a higher frequency of EGFR mutations. So this sort of idea of combined tumors sort of creates a pitfall. I think we're always worried that this is sort of a mixed non-small cell or a non-small cell with small cell. And so the question is, you know, for adenosquamous cell carcinomas, should I suggest that it could be, or could one component be benign or reactive? So I feel like my fellows always ask me, okay, I think they're squamous cell. Are these just reactive bronchial cells or reactive pneumocytes that are TTF1 positive, or vice versa? I see a lot of TTF1 positive cells, and I see a few squamous type cells that are P40 positive. could this be an adenosquamous cell carcinoma? So I think some of the things that you have to consider are clinical history, obviously smoking history. I think you have to be careful if you're going to make a diagnosis of squamous cell in a non-smoker. The other thing is people have proposed looking at nuclear grade, and then if you have an adenosquamous cell carcinoma, usually the nuclear grade of the squamous and the adeno component are pretty much in line. They're just either both high grade. If one is high grade and one looks more low grade or sort of benign appearing, sometimes that mismatch can maybe make you think that one's a reactive phenomena and really that it's not a combined tumor. Overall, we're lucky that these combined tumors are rare, but it does have important implications for testing, as I mentioned. So when in doubt, I think it's important to check the history. And if there's any suggestion that it could be sort of a mixed tumor with a squamous component, err on the side of calling non-small cell to prompt molecular testing. And this is just from the original molecular testing guidelines that came out. And I think this is an important statement that it makes, and that basically patients showing pure squamous or small cell histology or cytology with certain clinical criteria. And those clinical criteria are young age and a lack of smoking history. So if they're young and they are non-smoker and you think it looks like a pure small cell or a pure squamous, that those are cases that could benefit from molecular testing because it might actually be a combined tumor, which may make more sense. And so that's what prompted our clinicians to actually request a repeat biopsy in this case, because of her young age and her non-smoking status. The diagnosis of squamous cell just didn't make sense in that setting. So pitfalls in adenocarcinoma. So we've seen sort of, I think people want to put things into the adenocarcinoma category because it's TTF1 positive and then get molecular testing. And I think we have this sort of pressure on us to self-classify. And so sometimes I feel like maybe we're overcalling adenocarcinoma in particular situations, one being benign or reactive changes, like I showed you with the PD-1 inhibitor toxicity. And then we've also seen sort of a variety of sort of low to intermediate grade neuroendocrine tumors that come in with a diagnosis of adenocarcinoma. And I'll show you some of the sort of interesting features of those tumors. So these would be like your carcinoid or atypical carcinoids that have sort of rosette formation that are assumed to sort of be glandular formation, getting a diagnosis of an adenocarcinoma on a small biopsy. And then there's misclassification where you know it's carcinoma, and some people will call, squamous cell or large cell neuroendocrine carcinomas. Those sort of tumors without immunos, they can look like an adenocarcinoma. Other things would be like salivary gland type tumors of the lung, in particular mucoepidermoid carcinoma that can have signet ring type cells. Non-pulmonary carcinomas, metastatic to the lung, and metastatic melanoma that can look sort of plasmacytoid and almost look like a poorly differentiated adeno. So I always say, it's good to limit your immunostains, but there's particular situations where you want to be right. And so sometimes you have to expand your immunopanel to be right. And so we'll go over some of those situations. So this is actually a recent case that we had in Pittsburgh. It was a lung FNA in a patient who had an adenocarcinoma on a concurrent lung biopsy, and we were sent the cytology. And you can see here, it's a pretty cellular specimen. Some of the cells are sort of strip cells. Some look sort of plasmacytoid. And there's actually were a fair number of intranuclear inclusions. And so this was commented on actually on the biopsy that, this was favored to be adenocarcinoma because of the intranuclear inclusions. And you can see overall, a lot of it doesn't really have prominent nucleoli. And some of the glandular formation here is sort of, could it be rosettes? Could this be sort of neuroendocrine? It has a very sort of clean background. I think here, when you look at the pap stain, again, you sort of see sort of powdery chromatin with maybe some sort of small nucleoli in some cells. And again, sort of this vague sense of rosetting or glands and things like that could easily make someone think of an adenocarcinoma. This was sort of the cell block where actually synaptophysin was done and was strongly positive. And this is the surgical, and you can see sort of that sort of glandular-like arrangement, which is something that was also seen on the cytology, and also these very bubbly nuclei with intranuclear inclusions. And I think when we see intranuclear inclusions in the lung, we always think about lipidic type adenocarcinomas, which used to be the old bronchoalveolar carcinomas. But it is important to realize that you could see these sort of bubbles in the nuclei or intranuclear inclusions in neuroendocrine tumors as well. And you look in the literature, there are sort of rare reports of this. It's not sort of a well-known fact that you can see these intranuclear inclusions. But the thing I wanted to highlight was that neuroendocrine tumors can have this sort of rosetting that looks like glandular formation and can have the intranuclear inclusions in rare cases. And so we always sort of simplify it with 3 immunostains. We pretty routinely do TTF1, synaptophysin, and P40. And I think that can really sort of decrease errors and decrease missing these sort of these well-differentiated or intermediate grade neuroendocrine tumors. I also think that sometimes metastatic breast carcinoma has this very benign, bland appearance, almost like a well-differentiated neuroendocrine tumor or a well-differentiated adenocarcinoma. So this is another case that we did. This is a touch prep of a core biopsy of the lung, of an endobronchial biopsy. And on-site evaluation said adenocarcinoma. You can see sort of these complex, like sort of 3-dimensional groups with some nuclear atypia. And I always think sometimes these touch preps of core biopsies are hard to evaluate. They sort of get these big, thick clumps. You really worry that you're getting too much tissue on the slide and not enough is going in for the cell block. We don't touch all cores, but sometimes when there's an issue of prior testing or something that doesn't make sense and they want us to evaluate it, we'll evaluate it with a touch prep. And one of the things that sometimes helps me, because I have a hard time sometimes subtyping non-small cells on site, is that with squamous cells, sometimes you can see sort of this tigroid-like appearance around the clusters when they're very 3-dimensional and complex. And as we know, sort of the poor man's test for squamous cell used to be a PAS stain to look for the glycogen. And so just as we see with seminomas, you can see sort of that tigroid-like appearance on a diff-quick stain when you do a touch prep. And I find that can be a little bit helpful for me sort of backing off from calling something adeno and just saying non-small cell or favor squamous cell or something like that. So this was actually a squamous cell carcinoma on biopsy. As we know, sort of basaloid squamous cell carcinomas can have this sort of rosetting or gland-like arrangement as well. And large cell neuroendocrine carcinomas can have sort of moderate amounts of cytoplasm and prominent nucleoli. And I think some of these are really tough without being able to do immunostain. So I think some of our misdiagnoses of adenocarcinomas are on those consult cases or the cases where they have no cell block. And we think we can just sort of call it adeno without confirmatory studies. And so you have to be careful in a subset of cases if you don't have immunostains. And as I mentioned before, if you do have enough for immunostains, doing TTF1, Synapto, and P40 can make your life a lot easier in some of these cases. This is another case that we recently had. This was a mucoepidermoid carcinoma in the lung, and you can see sort of this bronchial mass. And on-site evaluation was like favor adenocarcinoma, and you can see why. There's sort of these large cellular groups. A lot of it sort of looks almost papillary. And on the pap stain, you can see some small sort of nucleoli. Some cells have more dense cytoplasm, sort of imparting more of a squamoid look to them. But you do have a lot of these sort of signet ring type cells, and that could easily make someone assume that a case is an adenocarcinoma. So this was a mucoepidermoid carcinoma. It's easy with stains, obviously, because the cells that you think may look glandular are actually P40 positive and do have some use in vacuoles, and TTF1 is negative. And then there's those scenarios where you think it looks, like an adenocarcinoma, but it has some weird features that may prompt you to think about a non-pulmonary metastasis. And, renal cell carcinoma is something I feel like we see everywhere. And, the discohesive cells and the prominent nucleoli could easily make someone think of just an adenocarcinoma. But sometimes those sort of metachromatic sort of lace-like material between the cells and sort of the punched out vacuoles and transgressing vessels can be sort of helpful clues that maybe you're not dealing with a lung cancer, but maybe it's a non-pulmonary tumor. So just the take-home messages from this case is that subclassification can be difficult in a subset of lung tumors. And I really think a good clinical history is important. I sort of will usually err on the side of not calling something small cell or squamous cell if I have a young non-smoker. And I think that's an important message that those patients may have a combined tumor. And I think accurate diagnosis is really essential, and it's not always an easy just adenocarcinoma case, and the immunostains can really help you. And although we want to avoid unnecessary testing, you want to do just enough to be correct, and it's figuring out what panel to do in certain situations. Okay, so my last case is a CT-guided FNA and a core biopsy with touch prep. And this was kind of an interesting case in an 82-year-old woman who had this very sort of well-circumscribed coin-shaped lesion in the upper lobe of the lung. And she had a prior CT-guided FNA that showed pulmonary hamartoma. But to the clinicians, it was growing on imaging. And usually that's sort of a no-no for hamartomas. They really should not grow at all. And so she came for a repeat FNA and core biopsy with touch preparation. And you can easily see why it was called hamartoma. It has this sort of troll doll-like metachromatic material on Diff-Quix imaging. And I think the real tip-off here is that it seems to have more cells than I'm sort of used to for a hamartoma. Some of them look sort of spindly, some more epithelioid, and they're sort of intermixed within this stroma. And some of the areas actually did have a little bit more cellularity as well. And this was the core biopsy. They said, you know, we're just going to do a core biopsy because last time they did an FNA and the clinicians just want us to do a core. So they did a core of the more solid appearing area. And you can see sort of these little sort of lumens with eosinophilic material. And it almost looks like there's sort of two cell layers to some of these groups where you have sort of these spindly type cells and the more epithelioid cells on the center. Here you can see on the cell block, you really do see more of that sort of fibrillary stroma. And if you didn't tell me what organ I was in, I would say this looks like almost like pleomorphic adenoma, like we see in the salivary gland. So these are the stains. So you can see S100 sort of highlighting that second group of stains around these sort of lumens and the cytokeratin staining on the center of those lumens, sort of favoring sort of a salivary gland type tumor with at least some myoepithelial component and possibly an epithelial myoepithelial carcinoma. So biphasic lesions in the lung, not always hamartoma. You should think about a variety of different salivary gland type tumors. Salivary gland type tumors can happen in the lung as primary tumors arising from the bronchial glands, but always you need to sort of rule out a metastatic lesion from the salivary glands. And this sort of highlights when those lung tumors really don't fall into your typical small cell or non-small cell, that they can be quite challenging. So this patient actually had a lobectomy, showing a well-circumscribed lung lesion that was a carcinoma ex pleomorphic adenoma, and the carcinomatous component was indeed an epithelial myoepithelial carcinoma. So it's interesting because I think a lot of that hamartoma-like troll doll hair was the PA component, and then the core biopsy kind of caught more of the EMC component. So carcinoma ex pleomorphic adenoma in the lung is rare, arises from the bronchial glands. You really have to exclude a head and neck primary clinically. It's considered a low-grade malignancy with a long interval to recurrence and metastasis. And when you see carcinoma ex PA in the lung, the most common carcinomas to arise in these PAs are poorly differentiated adenos, salivary duct carcinomas, and the EMCs. And grossly, these will have this very well-circumscribed pushing border, just like you would see almost with a hamartoma. Histologically, it has this sort of chondromyxoid stroma with these myoepithelial cells and the telltale sort of duct-like structures. And really sort of the key thing to note the absence of is that there really is no mature cartilage, which we usually see in pulmonary hamartomas. In addition, a lot of these cases will show some atypia and more naked nuclei, which would really not be something that we would see with the hamartomas. So the differential in a case like this would sort of be your amyloid or sort of other sort of material in the lung, hamartomas, variety of different mesenchymal tumors, spindle cell tumors, and then primary lung cancer with sort of a desmoplastic-like stromal reaction. As I mentioned, the pulmonary hamartomas, usually there is this sort of mature cartilage component, which you don't see in pleomorphic adenomas or the carcinoma ex pleomorphic adenomas. Other things that you can see in the lung, obviously, almost any salivary gland tumor can occur and arise from the bronchial glands. We've seen a fair amount of adenoid cystic carcinomas arising from the bronchial glands. And of course, these look very similar to what you would see in the salivary gland. Lucky for us, there are a variety of different FISH studies that can be done now for subclassification of salivary gland-like tumors, whether it's in the salivary gland or in the lung. And these can be very helpful if you're thinking about certain tumors. The mucoepidermoid carcinoma that I showed you earlier in the lung actually did have the MAML2 FISH rearrangement. So these are helpful in a variety of different situations. And then, you know, there's primary lung tumors that can look like a salivary gland type tumor. I always think basaloid squamous cell carcinoma sometimes has this sort of hyaline material that actually looks adenoid cystic-like. And so obviously these will stain with squamous markers and can really mimic adenoid cystic. So take-home messages from this case is that pulmonary hamartomas really don't grow rapidly. So if you see what looks like a pulmonary hamartoma and they're telling you it's growing, that's sort of a red flag to think maybe more of a salivary gland type tumor. And although salivary gland type tumors can occur as a primary in the lung, they're rare and you should always exclude a prior metastasis. And FISH studies could really be helpful in a subset of these cases if you're thinking of a salivary gland type tumor. So in conclusion, minimally invasive biopsies and new FNA techniques have really changed the way that we approach mediastinal and thoracic lesions, and it's really improved patient care, being able to get more tissue with small needles in these patients who really wouldn't benefit from invasive surgery. We also have new classification systems that sort of guide and provide a framework for us and sort of how we should be formulating diagnoses in these small biopsies. And I think that has helped sort of increase concordance amongst our community. As we know, biomarker testing is crucial and growing, and really making sure you're getting enough in your small biopsy and not doing too much or too little is important. And hopefully with these 3 cases, I showed you some small biopsy and cytology diagnoses that can be challenging and things that you should think of in the back of your mind when things don't sort of fit the bill for being exactly as adenocarcinoma or squamous cell, and what other things you should think about. And with that, I'd be happy to take any questions, or if you want to leave questions for the end.
Good question.
Okay. Yes.
Regarding the adenosquamous, it is of course rare, less than 5%. However, there are some reports that in cytopathology in terms of FNAs can be overdiagnosed or seen more. Have you ever diagnosed adenosquamous on an FNA? I mean, I know that I cold cases carcinoma with glandular and squamous features.
Yeah.
Based on the immunostains and.
I think that's what we used to call it, was carcinoma with squamous and glandular features. And now with the ISLC guidelines, you really just want to put that in non-small cell NOS with a comment saying that you see squamous and glandular features. You obviously don't want to overuse that non-small cell NOS. And most of us triage for molecular testing off that diagnosis, with the event that you really can't exclude an adenocarcinoma component. And I think that's really the push from the guidelines. When you are not certain, you cannot exclude that there's an adeno component, that you should err on the side of calling it non-small cell, give whatever comment you want about what features you see, but that patient will then get appropriate testing to see if there is a driver mutation. And sometimes that driver mutation is revealing, right? If she's EGFR mutated, in a case that you called squamous, it's obviously more obviously going to be adenosquamous and not a pure squamous cell carcinoma. So it can help in some cases. Yeah.
I have a question regarding molecular testing.
I'm interested in how is your view on doing molecular testing on scrapings from the slides, air dried and alcohol fixed, and is it ready for prime time?
Yeah, I mean, I think, you know, different institutions approach this differently. I think because we have a surgical pathology driven society, and, you know, a lot of places don't want to revalidate everything off alternative methods. A lot of people just do everything formalin fixed cell block for all testing and don't necessarily have to revalidate for all the things that they're doing on their surgicals. Sometimes people are doing it off the smears as sort of a secondary method if for some reason your cell block has nothing, to avoid a repeat biopsy. So I think it's helpful as a backup method if you don't have enough in your cell block, if it's going to prevent a repeat biopsy. But you have to think about, you know, if they want PD-L1 testing, so if they're going to repeat the biopsy for testing like that, then maybe doing all that labor and work to get your material off the smear for NGS is not going to give them all the informative results they want. And sometimes I think you just have to bite the bullet, and it's going to require a repeat biopsy. So I think it's important to minimize those type of cases. I know some institutions have great success with it. We don't like to put the effort and time into doing it, especially when there's a growing number of things we want to do, and a repeat biopsy is usually done.
I have a comment on that.
Yeah.
In the 2013 CAP guidelines, we know they advocated for formalin fixed paraffin embedded tissue for all these NGS testing, but now they have included in their draft for the 2016 CAP guidelines the smears detection, extraction of DNA from the smears. So maybe your prime time will be.
Let's see. More questions?
I just have an operational question.
Yeah.
You said that your cytopathologists aren't going to be going for these procedures anymore, and they're going to be doing telecytology.
Correct.
So I was just wondering, is there a cytotechnologist that's going to be there doing the on-site assessment and transmitting you an image?
Good question.
Or are you doing like an LV1
Wait.
where you're loading the instrument and having someone else who's not pathology?
We are having our cytotech still go on site with our resident or fellow. And only the cytopathologist will be remote. So that cytotechnologist will prepare the slides. And the only real difference in the workflow is that once that slide is ready, they have to load it into the microscope and have good locator skills to actually show us the key cells of interest. If we have a resident or a fellow on service, they will also be on with the cytotech. They will be on that side of things, not on our side.
I just have one more question and then we'll break.
Hi, I'm one of the oncology fellows.
Yeah.
Here. I have a question for you as well as the other.
Sure.
So you mentioned you use a Ventana assay for PD-L1.
Uh-huh.
I don't know which assay we use here, but do we have a consensus as to which assay is best? Detecting,
There have been a couple of studies looking at all of the different antibodies, the DACO 22C3, 28.8, the Ventana SB263, and really a lot of them have enough concordance that really it's, as long as you validate it, you can basically use the antibody that's easiest for your lab.
and can they be compared to each other as well if you're from a different institution and it's a different test, and you redo it at your institution, and you have to compare one?
Usually they are concordant. It depends on whether, there is some heterogeneity with some of these antibodies. And so if you're looking at different biopsies, your values may be a little bit different. But usually if they're looking at membranous staining and giving you a tumor proportion score, a TPS, it should be in the ballpark. If there's a discordance, that would be something to sort of look into. But for the most part, the studies are showing that the antibodies are pretty much interchangeable. I think the best test is obviously if they're screamingly positive, greater than 50%, how, and if they're not positive, and then how they do on follow-up with the drug.
Just a piece of practical information. At Ranixville, PD-L1 means that the tissue goes for 22C3 antibody, which is approved for Keytruda, which is the only drug on market that requires tests to be done to be approved. So unless you request specifically for other antibody, we'll default to 22C3 for Keytruda. Thank you. So let's break for 10 minutes. Thank you, Dr. Monaco, for a very informative talk. And now it's 7. Let's be back here at 10 minutes past 7. Thank you.
Hey, how are you?
Oh, I know.